So then the nomenclature, then they'll call this eccrine poroma or juxtaepidermal poroma. We always go over this, but if it's in the epidermis, I think they still test you on this. If it's just in the epidermis, then it's hydroacanthoma simplex, or if it's just in the dermis, dermal duct tumor. Yeah. Yeah, I gave you 2 cartilage clues today, so on that accessory. So yeah, but really, so the epidermal changes can kind of vary from clinically and histologically. You can have complete ulceration. It can just be really atrophic. You get that kind of wrinkly clinical look when you see that. Sometimes you get hyperplastic, a little indented. This is a little hyperplastic and indented, and then usually you see underneath this vascular proliferation. It kind of heaps up around the edges here. So that's part of it, and just right under this sort of homogenized, sort of degenerated collagen right in here. And I always kind of talk, you almost like, if it's not so obvious with this cartilage and you're wondering, you almost get this kind of arc effect of the degenerated collagen. But that vascular proliferation is sometimes helpful when I get superficial shave biopsies that are like this, and you get a little bit of this vessel stuff right here. That can sometimes clue you in that it's kind of a reparative reaction to the trauma from sleeping on that. So, all right, CNH. This one could come with a differential. So what would you put on the differential? That's what the diagnosis is. Yep. CARP, right? SK, epidermal nevus. So, yep. This was acanthosis nigricans. Clinical, very helpful on that. So, okay. This one we got a couple weeks ago. Anyone? A tougher one? What's that? Well, this is a person, I think this was African-American patient, so that would be normal kind of pigment. No? See these lymphocytes in the epidermis? Yeah, MF. Yep, and let me just kind of take you through that. All these little lymphocytes here. Let's go on higher power. See that? Some of them even have halos. A little bit of a halo on, let me focus here, a little bit of a halo on this one here. See, it's a little bit cerebriform. It's a little bit enlarged from your typical lymphocyte, a little bit hyperchromatic. So there's a little bit of atypia. They really do kind of stand out when you see them. And then a lot of little lymphocytes within here. This one's got a little halo around it. These have halos, so yeah, so that was MF. Yeah, I think it was African American, and then it was hypopigmented clinically, the lesions were, so. Okay, this, got that? Good, okay.
Those are nice.
What's that? Yeah. This one? Warty dyskeratoma, yep. Endophytic, acantholytic, dyskeratotic. I always say if we were starting to think about could it be Grover's, well, Grover's pretty much stays in the plane of the epidermis at this level here. This is really an endophytic kind of neoplasm. This one? LP, yeah, LP. If you want to just have a differential, lichenoid drug, LP, BLK, yeah. Yeah, so LP. And this one? Syringoma, yep. Fibrotic stroma, really little called tadpole structures. Usually a superficially placed benign tumor. You guys' thoughts on this one? It's not a home run, like classic one though. So this was from a scalp, and so I'll see you got some dyskeratotic keratinocytes here. No, that's sorry. But there is a follicular porokeratosis that I have in my collection of the nose, it's called. But so dyskeratotic perifollicular fibroplasia, and then some lymphocytes around here. I said this is not the greatest example. So this was LPP. But if I really wanted a nice LPP case for like a board exam, I just want a nice kind of lichenoid lymphocytic infiltrate around here. So perhaps this is a little later stage lesion. And obviously kind of clinical fell into this thing as well. So it's not like I can just pick this up and just say LPP, you know, that's it. I know there are possibilities. So.
Does the fibrotic remodeling work?
Yeah, right over here. Kind of got a remnant. You can kind of see this sort of remnant of where a hair follicle used to be, but this, I don't know if this is exactly a streamer. It's sort of, yeah, I don't think we're exactly seeing a nice one here. And in the pathology, you know, if this was a nicer example where it was lichenoid around it, it's identical pathology to frontal fibrosing alopecia. So it's the same kind of pathology. Thoughts on this one? Yeah, guttate psoriasis. Yeah, you could have a differential if you really wanted on this one here with tinea, impetigo, pustular psoriasis. It's really got a nice spongiform pustule sort of formation. So, you know, if you didn't have that, just some aggregates of neutrophils subcorneally, larger aggregates, subcorneal pustular dermatosis, AGEP/spongiotic, you know, drug. Those are all be things you could start thinking. But I see the nice spongiform pustule formation, really points to psoriasis. And then guttate psoriasis / early eruptive psoriasis. There is some spongiosis in here, which you can see. It can be a little tricky, but anyway, okay, guttate psoriasis, good one. What you guys think on? We're on number 63. PRP, yeah. This is a nice example of it. The parakeratosis, although the slide's a little heavily stained, alternating parakeratosis and orthokeratosis. Para. See, it's alternating both planes, really. Para, normal para. And then after that, then you've got, although the hypergranulosis in this case isn't so great, but typically hypergranulosis, the acanthosis isn't usually psoriasiform, although it is in that other piece a little bit. It's usually a little irregular and they're more broad-based buds, rather than psoriasis is regular and these real thin kind of acanthotic bands. These are more broad-based. And then you just get a mild lymphohistiocytic infiltrate. If there was a differential with psoriasis, you don't see the neutrophils in the stratum corneum here, as opposed to a psoriasis where you typically, like we just saw in that other one, get some neutrophils. And then a subtle little thing, sometimes you can get a little bit of acantholysis, just a little few foci of acantholysis within a PRP lesion. So, but that's good PRP. This one. Accessory nipple, yep. You get a little bit of a epidermal hyperplasia, cynocentrally. You can get some associated sebaceous glands. You got the smooth muscle bundles, and then you even got a little gland right here. That kind of indented sort of hyperplastic center. And this one, solar purpura, yeah. You guys are probably looking for some exotic diagnosis or KS or something you're probably thinking, but yeah, just solar purpura. This one. Tumid lupus, so superficial and deep, lymphocytic, pretty much strictly lymphocytic, infiltrate with some mucin. And in the mucin, there was actually a fair amount of mucin right in here, all this blue stringy stuff in here. So tumid LE. And maybe a little edge of a follicular involvement here, but you know, you take out some of the mucin, that might take you more to like a Jesner's. But there's some overlap in those two. So. Okay. How about this one? Yeah, eccrine spiradenoma. This, all the residents are always good with eccrine spiradenoma. This particular slide, sometimes throw them off a little bit because that hyaline stuff almost like takes over in some of these fields, which this is just a little, but here, this is a little bit more typical eccrine spiradenoma. Starting to get a little cylindroma-like over here, but these are larger. And then here, it's just, I've just never seen this hyaline kind of take over. So eccrine spiradenoma, good. All right. Wow, I didn't see this piece earlier, big chunk. And this one, you guys think on this? This was from the eyelids.
Oh,
yeah, yep, xanthelasma. Yep. Thin, it is big, look at this, yeah, so thin epidermis, stroma, and eyelid skin, it's just a little bit loose, that's why people bruise so easy, and then just these aggregates of, and this one, lymphangioma, you guys go with that? This was a good one. I have one of these, I think, in my collection. But. So we know we're acral, and pedicuratolysis, yeah. So the tinea nigra organisms will be much larger, will be a little bit darker, yeah. And it's pitted. You see this right here? It's right here coming down like this. Kind of interesting one.
Can you go on that?
Yeah. Right here. Cool. Acral, and then yeah. On this one, the tough one is just thinking to know to go to that area. Almost like a nothing differential, sort of, but pretty hyperkeratotic. All right. This one. Yeah, and so as I say, there's not really much in the way of septal paniculatus to keep on your differential. So this is a septal thickening with a bunch of inflammation. I just go straight to erythema nodosum practically. And you do get a mixed infiltrate. You can get lymphocytes, histocytes, multinucleated giant cells. So septal thickening, a lot of inflammation, erythema nodosum. This adenoma, yep. Few layers of basal germinative cells. And if you start to get more and more layers and you get into the sebaceous epithelioma / sebaceoma, I don't think that they'll mess with you on the test and tell you the difference between sebaceoma and sebaceous epithelioma. So if they do, you can just pick one and hope you get it. And this, cylindroma, right? So we'll take you to that one. How about that? Yeah, pemphigus vulgaris. Yeah, it's going down to follicles. It's kind of, and a few of the areas, maybe it looks like it's going a little bit higher up, but essentially it's,
I like
always think also he was visual types. I love that.
Yeah.
And I saw that.
Yeah, and pretty broad. You know, these are usually broad lesions. Yep. So pemphigus vulgaris. And this. Yeah, it's basically, I think clinically this was an LSC kind of thing, but, you know, this could easily be LSC or prurigo, so, histologically. This was a poor staining one or something, but think on this. Say solitary lesion. Be okay. Yep. If they had 100 lesions, LP, but yeah. Be okay. Yeah. Mixed tumor of the skin / chondroid syringoma. Just these ductal spaces that can vary, acrine, apocrine. The arrangement can vary. That's what they call it, mixed. Everything's mixed. The stroma can vary from cartilaginous or chondroid to fibrotic to mucinous. So it just has all these epithelial and stromal sort of mixed variability, but very well defined. This is usually one that residents recognize pretty easily, pretty quickly after you've seen a few of them. All right, this one. EM. This nice EM. The stratum corneum is still intact, so this was kind of a quick hit interface dermatitis. If you wanted to sound smart, put some other stuff on the differential. What else could you say? Fixed drug, and would usually, definitely, this could look at fixed drug. You're going to also, to change that more to fixed drug, superficial and deep, maybe throw in some eosinophils. GVHD, acute GVHD, yep. And, I mean, you know, if you had a little bit of mucin in here, you know, and you had a particularly strong kind of interface dermatitis or connective tissue disorder, occasionally just a straight drug reaction can give you kind of an interface process like this, but this is great for EM. And this one, PN, palisaded, encapsulated neuroma. All right, let's get this one. ALHE. Everybody see that?
No, I don't.
No? Okay, all right, that's good. Well, ALHE, yeah, ALHE is I would say, vascular inflammatory neoplasm, and it usually does occupy this kind of large, clinically, it's a little bit more into papule. They start to get to be kind of papular nodules. And so just think of the name ALHE, angio, and even at this power, you can kind of see the prominence of these vessels. So that's a component of it. So these little prominent vessels. Angio, lymphoid, you know, you got these little, almost feel like lymphoid follicle. I mean, there's just like little areas of kind of dense inflammation scattered throughout here. So angio, lymphoid, hyperplasia with eosinophilia. And then we went on a little higher power. And the EOs, there was actually a fair number of EOs kind of all through here. These EOs, so. Angiolymphoid hyperplasia with eosinophilia. How about this? DFSP, yeah, it's always honeycombing, monotonous, densely packed, small spindle cells intersecting, storiform arrangements. So DFSP. This is more of the storiform, I would say, right here. Nice classic storiform arrangement. That's much over here, more fascicular here. And this one, trichofolliculoma, yeah. So you got a central follicular dilated pore, and emanating from that epithelium are all these kind of secondary, hair follicles, kind of primary and secondary hair follicles, less mature arrangements of follicles coming off of that. Lesser variant, where instead of all these small follicles coming off, they could be sebaceous glands coming off, so it could be sebaceous trichofolliculoma. This one, this one was DLE. Yep. LPP. There's a lot of epidermal stuff happening here and follicular plugging, but that's the kind of inflammation I wanted for that other LPP that we saw. So I'd like to take that inflammation somehow, stick it on that other slide. But so yeah, this is DLE. So you got a little bit of compact hyperkeratosis, epidermal atrophy, little basal vac, follicular plugging, perivascular, perifollicular, pretty dense lymphocytic infiltrate. And at low power, the first thing often strikes with DLE is just at the lymphocytic inflammation. It kind of just takes over. It's very prominent. But then you got the follicular plugging and all those other findings. So it's good for, really good for DLE interface there. This NLD, right? Broad, sort of hypocellular bands in the dermis, separated by little zones of inflammation, lymphocytes, histocytes, occasionally some granulomatous foci within it. Yeah, inverted follicular keratosis. Yep. This one I kind of liked a little bit better than that other one for IFK, because that other one still had almost like an SK architecture. This one's good, really clearly follicular in its orientation and the way it sort of bands down along the follicle. This might be one for a differential. Yeah. So what do you think? GVHD could be on the differential. EM could still be a subtle. What was it? Dermatomyositis, LE. Yeah. And this one did happen to be dermatomyositis. So you get a little vasovascularization, and DM, the amount of lymphocytes in DM can, and as opposed to LE, although you can't say without the whole clinical one, the amount of lymphocytes in DM is usually sometimes very sparse, very few compared to LE, and then usually you get a little bit more mucin perhaps than LE, but you can't really tell so much difference. This comes with a differential too, right? So it would be AFX, mesomelanoma, SCC, Lamar sarcoma. Yep, those are all the kind of things. On a practical level, with this is almost always AFX with the degree of atypia. It's very striking atypia. Mitotic figures, atypical mitotic figures. I even earlier went in and honed in on almost like a enlarged histiocytic cell, so fibroxanthoma. And then the other one that I'll usually also keep Layomar sarc on this differential as well. But yeah, these get all stained and everything. But if you were pushed with no stains and you had to choose on a board exam, I'd probably go with AFX on this. Vesicular, strikingly atypical mitotic figures, densely packed spindle cells. This one I don't think I gave you much time on. So. Yeah, acral dyshidrotic eczema. This one, PG, right? Okay. If I'm going too fast, you need to pause, just let me know. Yeah, this was pretibial myxedema. So these
like that is myxedema, like all of.
Yep. So so pretibial myxedema, usually an abundant amount of mucin that really almost practically takes over the whole field. And here you can see that there's little strands of collagen remaining, but most of this is sort of clear spaces. Really no inflammation, really no cellularity. They just dropped a bunch of mucin on it, and that's pretibial myxedema. Scleromyxedema, or It goes by so many names. Fibrosing dermopathy, or whatever they call it now. Systemic what do they call it now? Nephrogenic systemic fibrosis, or yeah, whatever. Yeah, so that and scleromyxedema are very similar. So you get mucin, not this much, but some mucin increase, but also a very cellular kind of fibroblastic proliferation within the whole dermis, along with some mucin. So that's for scleromyxedema / fibrosing dermopathy. We saw sclerodema adultorum of Buschke, where you have and that dermis, I don't know if I commented on, the dermis is super thick, and you'll get some mucin kind of mixed in there, no real inflammation, none of the fibroblastic sort of proliferation that you see with scleromyx / fibrosing. Focal mucinosis is usually higher placed, and if you had the whole thing excised, you'd just see a small focus and the dermis just filled with mucin, whereas pretibial mix is kind of taken over a whole zone. I think that's the main ones. So, pretibial myxedema. This one. Yeah, PF. Yep, pemphigus foliaceus. You can see where it starts right here. Yep. This one just came. I just read this a few weeks ago. I was surprised. Anybody know this one? Pancreatic Paniculitis, yeah. Yeah, these are the characteristic ghost cells. So you get this sort of necrosis. So there are a lot of here necrosis and some secondary kind of inflammation there. A lot of calcification, and then these classic sort of ghost cells in this area here. This is Chris's patient. No known history of any pancreatic issues, just not feeling good, GI symptoms. So I don't know, I'll have to check with her what happened, but I have not seen this in a long time. This one I kind of took you into the...
Yeah.
I'll say this one, you know, not the easy instant home run, because the cells aren't just jumping out and taking over the whole area, but you start to look around in some of these, and you see here, this is really just, once you get to this right here, very diagnostic. And if you're having trouble finding it, and it's true, they say kind of go to the edge, because maybe this stuff's all just been, maybe the center has sort of aged and it's necrotic and inflamed. There's nothing left that's diagnostic for the viral changes. Go to the edge. And you can even see out here at the edge, starting to see some multinucleation, and then here this is just diagnostic. You'll see even here just some remnants of right here, similar multinucleated cell there. So anyway, herpes virus infection. This one was good, straightforward, right?
Yeah.
Yep. And Teuton cell has a central area of the cytoplasm, nuclei lined up at the periphery, and peripheral to that, this sort of vacuolated area here. So that's what a Teuton is. This one, digital mucocyst, digital mucoid cyst. And then to contrast with the one we just saw, what do you guys think on this one? Yeah, reticulohistiocytoma. Yep. So really similar architecture as that JXG, no Teutons. And the cells are just different from the other one. You have these sort of large amphiphilic cytoplasm, a lot of cytoplasm. You almost question, like, is this some sort of tumor? You know, it's just the cells are so large. And it's got that nodular architecture. You can get all kinds of mixed inflammatory cells in JXG and in this. This one happens to have tons of eosinophils over here. And it's just an inflammatory component to it. So, reticulohistiocytoma. How about this one? Gout, yep. And actually a little perforation of the gout you can see here. through a hair follicle, or just straight perforation. So yeah, this is gout. You get these sort of crystalline structures in the dermis. This is one of our patient, African American guy, came in. He was referred by PCP for excision of, you know, like, I don't know, 8 or 9 cysts all over his ears, like on the rims of his ears. So they look cystic. But. All right, anyone on this one? Yeah, yep, myxoid neurothelioma. Yep, very good. Just don't see as many of these. I think theek is some sort of word for like almost like, I may be wrong, but some sort of like a zone or some sort of like theme kind of thing. So you've got these little sort of, I would say almost like ball areas of involvement with these little thin sort of spindle type of cells within a mucinous stroma. So there's just multiple little areas that have that kind of almost like a multinodular sort of thing. So I'm not explaining that very good, but pretty well defined little areas. And then as we go in, there's the thin spindle cells within myxoid stroma. Really nothing else that kind of looks like that. So